Chapter 24, Urinary Physiology, Screencast 2. Now, this may differ a little bit from something that you've seen previously. I did delete some slides that address the function of the renal system. I did not want to duplicate them in this particular screencast as they were addressed in the Chapter 24 Urinary Anatomy screencast. Couple things that I want to address here before I really get started. I am not a big fan of using the term urinary system. That is more of a structural anatomical identification as opposed to the renal system, because that is the organ as far as the kidneys that accomplish everything that is happening in urinary or renal physiology. So please keep that in mind. In the previous set of screencasts, we actually introduced the nephron as the functional unit of the kidney, and we are going to continue that. So keep in mind, we are talking about a single nephron, but think about how many nephrons we actually have in our kidneys. Now, what I want to point out first is the concept of processes, and these three processes are basically result in the formation of urine. And basically, these processes result in the functions of the kidney that were addressed earlier. So the first process is glomerular filtration, and this actually happens within the glomerulus itself. So we are talking about the movement of substances from the blood within the glomerulus into the capsular space. Tubular reabsorption, this is the movement of substances from the tubular fluid back into the blood. Tubular secretion is the movement of substances from the blood into the tubular fluid. It is really important that you understand these processes because they overall result in what the kidneys actually do in the role of maintaining homeostasis. Now, the first thing that we have to talk about is the filtration membrane. So let's take a look at this particular image here. And notice the first thing here. We're basically looking at the glomerulus, and we're also going to see some visceral layers of the glomerular capsule. And so we have the capillary lumen, and notice once again, this is the glomerulus itself. And what we want to take account of here is the filtration membrane. This is made up of the endothelium of the glomerulus, the basement membrane of the glomerulus, and filtration slits that are formed by the visceral layer of the glomerular capsule. Here we actually see the visceral layer of the glomerular capsule, but once again, I want to put the emphasis actually on the filtration membrane, as this is where the process of filtration is actually occurring. We already addressed some significant anatomical differences between the afferent versus efferent arteriole, with the afferent arteriole having a greater diameter than the efferent arteriole. This is going to help produce a hydrostatic pressure that will be driving filtration. Now, the next thing we have to address is what is actually filtered by the filtration membrane. And what we want to take a look at here, what is actually filtered, and that will be filtrate, includes water, glucose, amino acids, ions, urea, some hormones, vitamins B and C, ketones, and very small amounts of small proteins. So that is important to keep in mind. So notice what is not filtered. What is not normally filtered will be large proteins and formed elements. That is especially important that we understand what can get through the filtration membrane and what cannot. Now, I've addressed this previously, and I think it is rather fascinating when we break down and look at how hard our kidneys work on a daily basis. Generally, healthy kidneys are producing 180 liters of filtrate produced daily. Now, keep in mind, this is an ongoing process of filtrate that's being produced, but also it is going to be reabsorbed. Now, this filtered plasma with certain solutes and minimal amounts of protein is going to be caught within the capsular space, and then it will move into the proximal convoluted tubule. Materials that are not filtered will remain in blood, exit the renal corpuscle through the efferent arteriole. Now, there is some material that's filtered that will be trapped within the basement membrane. This is generally going to be phagocytized by mesangial cells. Now, how we want to describe things are three categories of substances in blood. Freely filtered, this is going to be small substances. For example, water, glucose, amino acids, ions. These are substances that pass easily through the filtration membrane as they are small. Things that are not filtered will be formed elements and large proteins. They're just too large to pass through the filtration membrane. Now, limited filtration, this will be proteins of intermediate size, usually blocked from filtration due to the size or due to negative charge. Now, glomerular hydrostatic pressure. This is the blood pressure within the glomerulus. This is responsible for pushing water and some solutes out of the glomerulus and into the capsular space of the renal corpuscle. Now, one thing to keep in mind here is the blood pressure in the glomerulus will be higher than the blood pressure of other systemic capillaries. And this is due to a number of reasons. One, you need a higher pressure for filtration to take place, and you have a large diameter of afferent arteriole versus a smaller diameter of the efferent arteriole. What this actually means is it is easier to get in than it is to leave, so you'll have some accumulated fluid that will actually assist with the process of filtration. Now, keep in mind what we're addressing now is something very similar to what we saw previously with filtration at the capillary level. And so we're going to use that as an example. So we are going to refer to osmotic or oncotic forces. Remember, those are the forces due to protein as a non-permeating solute. But we have to take into account an additional force because now, remember, the glomerulus is encased in a capsule, so filtrate can actually exert pressure as it accumulates within the capsule that will inhibit the process of filtration. So let's take a deeper look at these pressures. As noted previously, we have the blood colloid osmotic pressure or oncotic pressure. Remember, this is the osmotic pressure that's exerted by dissolved solutes. The biggest player is going to be plasma proteins. And remember, we want to think of proteins as non-permeating solute. And keep in mind that this is opposing filtration. So this is going to draw fluid back into the glomerulus, and I've referred to this previously as a suckage force. The new pressure that we have to take into account is capsular hydrostatic pressure. This is the pressure within the glomerular capsule due to the filtrate. And keep in mind, this is going to oppose filtration or more fluid making its way into the capsular space. Now, I'm not going to spend a lot of time focusing on the numbers, okay? The important thing to keep in mind here is that the major driving force is going to be glomerular hydrostatic pressure. It's about 60 millimeters of mercury. If we look at the opposing forces, we have the blood colloid osmotic force. That's approximately 32 millimeters of mercury. We also have the capsular hydrostatic pressure. That's approximately 18 millimeters of mercury. And what that does, it gives us a net filtration pressure that favors filtration of 10 millimeters mercury out. Now, a couple of things we have to keep in mind are the variables that are influenced by net filtration pressure. We have to take into account what's known as glomerular filtration rate, or GFR. This is the rate at which the volume of filtrate is formed. Volume per unit of time, usually liters per minute. And an increased net filtration pressure will increase glomerular filtration rate. It increases solutes and water remaining in tubular fluid, increases substances in urine, decreases filtrate reabsorption. So once again, if we look at an increased net filtration pressure, we are going to see an increase in glomerular filtration rate, an increase in the amount of filtrate formed, an increased solute in water remaining in tubular fluid, substances in urine, and keep in mind that a decrease will end up decrease filtrate reabsorption. Now, things to keep in mind here is the regulation of glomerular filtration rate, and this is a variable that is very tightly regulated. It helps our kidneys control urine production based on physiologic conditions. Examples, probably the predominant one will be level of hydration. Glomerular filtration rate is influenced by changing the luminal diameter of the afferent arteriole and also altering the surface area of the filtration membrane. So this is going to be made up of processes that take place within the kidney itself, and these are going to be considered intrinsic control mechanisms. Processes external to the kidney, such as sympathetic activity and hormones, will be considered as extrinsic control mechanisms. Now, the first thing we have to address is something similar to what we talked about before happening at the capillary level, and this is autoregulation. And so what this means is the intrinsic ability of the kidney to maintain a constant blood pressure and glomerular filtration rate in spite of changes in systemic arterial pressure. This is going to happen by two primary mechanisms. The first is known as the myogenic response, and the second will be the tubuloglomerular feedback mechanism. So let's take a look at these mechanisms in a little bit more detail. Now, what we're looking at here is basically the myogenic response depending upon what is happening to systemic blood pressure. So let's talk about decreased first. Now, I've addressed this previously. The body definitely takes more seriously a decrease in blood pressure as opposed to an increase in blood pressure. So let's take a look at what's happening with respect to myogenic response when blood pressure decreases. What this actually means, there is less stretch of the smooth muscle within the arteriole. This causes smooth muscle cells to relax, vessels will begin to dilate, and this is similar to what we talked about previously. This is going to allow more blood into glomerulus, and this is actually compensating for the lower systemic blood pressure, and the overall goal is to maintain a normal glomerular filtration rate within normal ranges. We can expect the exact opposite to occur when we have an increase in blood pressure. So now there's actually going to be a greater stretch of the smooth muscle within the arteriole. This now causes the smooth muscle cell to contract, vessels constrict. This actually results in less blood moving into the glomerulus, and this actually will compensate for the greater systemic pressure. But the underlying goal is to maintain glomerular filtration rate within normal ranges. So let's take a look at this particular diagram here. This is focusing on the myogenic response, and I want to start off with the middle panel. So this is what's happening under normal systemic blood pressure. So keep in mind we have normal systemic blood pressure, no real response or change in the diameter of the afferent or efferent arteriole, and we're going to have a regular or normal glomerular filtration rate. The next thing that we're going to look at is what happens when there is a decrease in systemic blood pressure, and that is actually addressed in the first panel. So look what happens. We have a significant amount of relaxation, so vasodilation of the afferent arteriole. This greatly widens the lumen of the arteriole, and it's allowing more blood into the glomerulus to offset the decrease in systemic blood pressure. So keep in mind, this is autoregulation due to the myogenic response when blood pressure drops. Now, when blood pressure increases, and this is shown in the last panel, we're actually going to see the opposite. Compare what's happened to the afferent arteriole to the middle panel, and we can see that it is vasoconstricted. We now have narrowed the arteriole, and that is going to result in less blood moving into the glomerulus, and this is actually going to offset any increase in systemic blood pressure. Now, the other mechanism that we have is the tubuloglomerular feedback mechanism. Now, I want us to make sure that this is not the primary mechanism, and this is thought of as a backup to the myogenic mechanism in response to increased blood pressure. So, if glomerular blood pressure increased, the amount of sodium chloride in tubular fluid also increased. This is detected by the macula densa cells in the juxtaglomerular apparatus, and this is actually going to result in further vasoconstriction of afferent arteriole. Now, something to keep in mind here is that there is a limitation to this process. You can only do so much. You can only vasodilate or vasoconstrict to a greater extent. Once you have maximized the impact of those mechanisms, we are now going to see some issues. And these are the limits. Now, when we talk about renal autoregulation, basically this will maintain a normal glomerular pressure when blood pressure is within the certain range, and that range is 80 to 180 millimeters of mercury. Now, when we see a decrease in blood pressure below 80 millimeters of mercury, arterioles are at their maximum dilation. There's going to be a decrease in glomerular blood pressure, and that results in a corresponding decrease in glomerular filtration rate. If this gets really low, you can actually result or cause the cessation of waste elimination in urine, and waste will actually accumulate in the blood. Any increase in blood pressure above 180 millimeters of mercury, arterioles are now at their maximum constriction. They can no longer constrict to a greater degree. This results in an increase in glomerular blood pressure and glomerular filtration rate, and this will result in an increase in the formation of urine. So here we can actually see what's happening. So we have autoregulation within a relatively wide range of mean arterial pressure, once again, ranging from about 80 to 180, okay? And we can see here generally what's happening as far as with a average mean arterial pressure. Excuse me. And notice glomerular filtration rate is relatively constant. When we see a significant decrease in mean arterial pressure, look at basically not enough urine is being produced. If we look at mean arterial blood pressures above 180 millimeters of mercury, we are now looking at an excessive production of urine. Now, what we have talked about previously were the intrinsic mechanisms. What we want to talk about now are going to be the extrinsic mechanisms. And the first thing that we're going to address is the impact of glomerular filtration rate through sympathetic activity. Now, what we're looking at here is neural and hormonal controls. And once again, these are referred to as extrinsic control mechanisms. And what we're looking at are physiological processes to change glomerular filtration rate in contrast to renal autoregulation in an attempt to maintain glomerular filtration rate. Now, when we increase sympathetic stimulation, that will actually result in a decrease in glomerular filtration rate. This is something that will happen during exercise or emergency. And basically, it's going to result in decrease in glomerular filtration rate. And this is happening due to vasoconstriction of both the afferent and efferent arterioles. The granular cells of the Golgi apparatus are releasing renin. We'll be addressing the renin-angiotensin pathway in greater detail in the next chapter. And this results in the production of angiotensin II. And as addressed previously, this is a very potent vasoconstrictor. Now, in addition to that vasoconstriction, we're going to see contraction of the mesangial cells. The contraction of these cells basically decrease the surface area of the glomerulus, and that will result in a corresponding decrease in glomerular filtration rate. So basically, what the body is doing under stressful conditions, it is conserving water. Now, when we look at the mechanisms that come into play when blood pressure increases, the only hormonal mechanism we have is atrial natriuretic peptide. So keep in mind, this is a hormone that's going to be released when there's increase in pressure, but that increase in pressure is due to something very specific. It is due to an increase in blood volume. So now, because there is a greater blood volume, there's going to be a greater amount of stretch occurring within the atria of the heart. This is going to increase glomerular filtration rate, and the process is a relaxation of the afferent arteriole. It's going to inhibit the release of renin, ultimately causing relaxation of the mesangial cells. This is going to increase the filtration membrane surface and result in an increased glomerular filtration rate. So this net increase in glomerular filtration rate with increased urine volume will decrease blood pressure by a lower blood volume. Now here we can basically compare the two mechanisms to each other. On the left, we actually have decreasing glomerular filtration rate through sympathetic activity, and the other panel is going to be increasing glomerular filtration rate through atrial natriuretic peptide, or ANP. Let's walk through sympathetic activity first. So the first thing that we have is some stimulus. It actually could be a stressor, it could be emergency, but let's imagine this is what's happening when there is a decrease in blood pressure. We're going to see sympathetic activity stimulate the kidneys, and what we're going to look at is vasoconstriction of the afferent arteriole. We're going to look at the granular cells of the Golgi apparatus. They're going to be releasing renin. This is going to result in the production of angiotensin II, and this is actually a very potent vasoconstrictor, but it's also going to result in contraction of the mesangial cells. The net result is vasoconstriction of afferent arteriole, and that's decreasing blood flow into the glomerulus, and the contraction of these mesangial cells are decreasing filtration surface area. The overall net effect is a decrease in glomerular filtration rate. There'll be a decrease in the amount of filtrate produced, and more fluid will be retained in blood, and that is going to result in a maintenance of blood volume, resulting in a stability or maintenance of blood pressure. Let's take a look at what happens with ANP, and remember, this is the only hormonal mechanism the body has that comes into play when there is an increase in blood pressure. And keep in mind that that increase in blood pressure is due to a very specific stimulus, and that is an increase in blood volume. So once again, the stimulus is increase in blood volume, or resulting in an increase in blood pressure. This stretches the wall of the atria, and this is where ANP is actually going to be released, hence the name. We are going to look at vasodilation of the afferent arteriole and relaxation of the mesangial cells. The result is vasodilation of the afferent arteriole will increase blood flow into the glomerulus, and relaxation of the mesangial cells increases filtration surface area. The net effect is an increased glomerular filtration rate. There's going to be a greater amount of filtrate produced, and because of this, more fluid is eliminated as urine, and this actually results in a decrease in blood volume, resulting in a corresponding decrease in blood pressure. Notice these are both negative feedback mechanisms.